Thank you. I would like to thank the association for the privilege of the podium, allowing me to present our experience for the last year treating complex esophageal perforations without operative repair. I have no conflicts of interest or financial disclosures. As we know, esophageal perforations have a high morbidity and high mortality rates. Traditional operative repair represents major procedures, high levels of morbidity, prolonged convalescence for our patients. We proposed to start using natural orifice surgery for contained perforations, allowing drainage, lavage, and focal decompression. Initially, our experience was with nasomediastinal tubes, and then we transitioned into cervicomediastinal tubes using a pharyngostomy, which may be a historical interest because it's not used very often anymore, but we found a use in this type of population. Our approach is we first do endoscopy, and we do an on-table esophagram with a 20-millimeter balloon occlusion at the GE junction to define the perforation. And if it's contained within the mediastinum and there's no leakage to the pleural surface, we manage endoscopically. If there's a free perforation into the pleura, we do an operative repair. Once we do that, we drain the infected cavity. We debride it with power triple antibiotic irrigation. We always do a percutaneous gastropexy and gastrojejunostomy to allow nutrition from day one, be able to drain the stomach and feed distally. We then place a cavity-directed nasomediastinal or a pharyngostomy tube over a fluoroscopy. We perform weekly endoscopic debridements. We retract the tube back as the cavity collapses and heals. These are the two tubes we use, normal saline sump on the left, and then there's a long Levine red rubber type of catheter that we use for pharyngostomy tubes. The other one is too stiff to put through the neck. For those of you who haven't seen pharyngostomies, we go behind the left posterior tonsillar pillar, and we use a long curved clamp and make a counter incision and put first an NG and then in retrograde fashion advance the Levine tube. And this is how it looks. And we treat it like a central line. These are some of our patients. You can see complex cavities. The one on the left was after an MIE. The other one was after TEE, iatrogenic perforation. The one on the right was a Boerhaave patient. These are some of the fluoroscopic images. The one on the left was a patient who had a redo Heller myotomy and outside hospital and had a very large leak. The other one was an esophagectomy. And the third one on the way on the right, you can see how long those perforations can be. We're almost at the edge of the chest, but that was all contained, and that's a picture of how the pharyngostomy looks. And you'll always get a call from radiology because they don't know what's going on with that X-ray. So it was a one-year experience, 6 patients with large complex perforations. 2 were post-operative leaks. One was an esophagectomy, and one after a redo Heller myotomy. One patient had a perforation after many esophageal dilations with ENT after a laryngectomy. One patient with achalasia after an episode of Boerhaave's. An iatrogenic patient after a TE during a mitral clip procedure for severe mitral regurgitation. And one was a patient with laparoscopic partial fundoplication at a community hospital. Two of these patients happened in-house, so the treatment was within 12 hours, and 4 of them was after 24 to 48 hours because they came from other institutions. Resulted, the patients needed a median of 4 procedures, ranged from 3 to 6, at a 4 to 10 day interval before we were able to remove the drain and initiate oral intake. We had two complications. One was an anastomotic stricture, and the patient who had an MIE at an outside hospital required multiple dilations. I think it was 4 or 5 afterwards. And one patient died, and it was the patient who had the TE perforation with a severe mitral regurgitation. She got septic, required fluids, and she spent a couple of weeks in the hospital but died, but her esophagus was healed with this technique. All the other 4 patients were on a soft diet 1 month after a removal of the drain. We learned initially that patients don't like tubes in their noses for a long time. They're very uncomfortable. They work, but they complain of pain, postnasal drip, sinusitis. So after the first 2 patients we did nasomediastinal tubes, we started thinking what we can do differently. So we decided to look at the archives and decide a pharyngostomy tube may work. So we tried it and it worked. And we avoid the morbidity and some of the discomfort of long-term nasogastric tubes. So avoiding the speech and swallowing impairments, septum trauma, epistaxis, alar necrosis, sinusitis. And we found that successful treatment with this complex mediastinal cavities from esophageal perforations can be achieved with continuous tube suction and repeated debridement without need for surgical repair. Now, you can use either natural orifices or pharyngostomy tubes to achieve esophageal healing. We found in our experience in this short series that pharyngostomies are more comfortable and better tolerated for patients. And I used to do endosponge before I did this, and I didn't have the pre-made endosponge. We had to do it all on the back table, and I just found it too cumbersome. And this has given similar results to the endosponge. And I think the key part, I didn't put it here, but is establishing nutrition day one. Adequate drainage, adequate nutrition are the keys for to allowing this to heal. Thank you for your time, and I'll take any questions now.
This paper is open for discussion. Questions?
Hey, Steve Leeds, Dallas. Great talk. Very similar to endosponge. My question is, you said in your algorithm, if it extends in a pleural cavity, you guys operate on them. Why not try your technique and just put a chest tube to help control the drainage? Is there any reason why you're operating on them instead of trying your technique on maybe a sicker patient or avoiding doing esophageal surgery? That's kind of why we do this stuff. So I'm just curious what your algorithm is.
Our thought is that if there's an ongoing leak, the driver for sepsis is still there. Even I think the control of putting a drain or an endosponge is not perfect. It's not 100% sealed. If it's contained and you don't have that huge absorptive pleural surface, your chances are that the patient's still going to get sick. If it's contained, two of those patients I managed outpatient. They would go home with this on a portable suction. They would come back for the procedures. If you have a free perforation, I don't know, our thoughts were those patients are going to get pretty sick. We should just do a full repair. I don't know if that holds validity or not, but that was our thought.
That was a great case series. And I know that every case is different, and when you're not there, it's hard to criticize. We all know what bad looks like. It's hard to put it in, cases. But you said that a large number of your patients were acute perforations. The pictures you showed weren't acute, but you said that a large number of them were acute. And I'm just wondering, why didn't you just use the notes procedure, go through the hole, clean it up, and then close it? That's number one. And number two, just sort of to go on to what Steve was saying, is that we have, luckily it's only happened twice, but we have had perforations that we've encountered that did go in freely into the thoracic cavity. And as far as you're concerned of not adequately draining them, you can use your scope to access some part of the abdominal wall and get nice drains in there and then close it or stent it or something like that. So just another tip. But I'm just curious about why you didn't close those acute ones.
Yeah, two of those patients that happened in-house. One was, we found out the next day after ENT perforated him, they didn't know, and then he was not doing well, and he already had a little cavity. He was looking pretty dirty, and he was very high up. These are really, really, really high perforations. They're hard to close endoscopically. And the other one was after TEE. So she was pretty sick. The quickest thing was just to leave a drain and get out. She was in like 3 pressors and already in decompensated heart failure. So that was, I think, the quickest thing to do.
So I'm going to exercise the chair's prerogative and actually pursue this discussion a little further, since we've got some really phenomenal experts in the room. So we've heard about the endoscopic vac therapy, and clearly that's gained a lot of traction and has had some really notable success. This is another modification of that. And I would ask you, as well as some of our audience members, what about the double J stents? So we're looking at some form of external irrigation / drainage to allow for control of what are largely contained cavities. And I'll admit a bias here. So we've been doing all of the above, and we've really gone to just using the double pigtails because it allows for internal drainage, it allows for control of the space and collapse of the space with much fewer interventions, much fewer endoscopies necessary to achieve the same result in terms of closure. Have you had experience with that?
I haven't used the double J stents, but I think it's 2 points. One, it's I think what's happening in trauma. Now they have the irrigation vac, so we're using that a lot more. So it's the same concept. And two, I think the key part is achieving good drainage, right? I think the type, color, and shape of the tube, is secondary. I think the key is you have good drainage of the cavity, you establish good nutrition for the patient, and that's how you're going to allow it to heal. I think we're all trying to learn which one is the best tube and which one we can avoid the most interventions for patient and make it the most comfortable.
But I think if you look at the way management of biliary sepsis played out in T tubes and then nasal biliary drains and then Who uses those today for managing biliary sepsis? Is all almost entirely managed with endoscopic biliary drains, right? Plastic or it's all internal. And then we saw the same thing happen with pseudocysts. And, you know, it was largely all managed internal drainage, and it turns out managing this a lot of the esophageal stuff is there's emerging evidence now that you can do the same sort of thing, just internal drainage, double pigtail stents, and that you don't actually need to have the external drainage component. But it's emerging, and it's a fascinating field.
Christy, I'd love to hear your
Yeah,
thoughts.
I mean, we haven't done a ton of these. We use the double J's a lot in the abdomen. That's great, and they seem to work great. I think for me, I wouldn't use it necessarily in the mediastinum unless the patient was pretty stable. You know, some of those ones that you described was like, get a big drain in there and get out and drain it, you know, but the double J's can clog, and they're not as big as a big tube like you had, so with more experience, you know, maybe we'll get bolder with those, but the cases that you had seemed like they were pretty ugly. And also, they seemed like the holes were bigger, like pretty...
A lot of tissue loss.
Like that you could actually get a big tube in there and a little double J might fall out, and we'll see. We'll see. It's definitely better for the abdomen.
It's an interesting concept, and I agree. It's completely in evolution, and it's going to be an exciting time to see how it evolves. One comment for the audience that doesn't do this is, you know, the irrigation that you're achieving with the initial endoscopy can't be underrated. You can do a tremendous amount of lavage and debridement in a stable setting with the initial endoscopy. But thank you. That was a great paper.
Thank you so much.